All right, well, welcome everyone. Thank you all for joining. It's my pleasure to welcome and get started with the webinar. We will be sharing some information and discussing the eXciteOSA mechanism for action, along with some real-world experiences of integrating this new therapy for snoring and obstructive sleep apnea into clinical practice. So I'll briefly introduce myself before I turn over to our speakers. So my name is Jessie Backer, and I lead the clinical and medical affairs team here at Signifier Medical. We make a new therapy called eXciteOSA, which is a neuromuscular electrical stimulation device designed to train the genioglossus during daily 20-minute sessions, which you'll hear more about in just a few moments. The device received FDA authorization through the De Novo pathway in February of this year. So it's now available as a prescription therapy, specifically for treatment of primary snoring and mild OSA. To date, so since about April, we've started around 1,800 patients on therapy. And amongst our clinical patients, so not those enrolled in studies, we are seeing just under 90% of people that have reached a threshold of 70% usage or 5 of 7 days on average. And of course, as the number of real-world patients increase, we'll have the opportunity to dive into those adherence data in more detail, as those metrics are remote monitored in a similar way to other therapy options. So it's certainly an exciting time for us as a company and for the clinical and medical affairs team in particular, as we're focusing on ramping up several new clinical trials. So this leads me nicely to introductions. So as I mentioned, this is me. I'd also like to welcome Dr. Brandon Nokes and Dr. Joshua Lennon, our speakers for today. Thank you both in advance for your time. Dr. Nokes is a pulmonary and critical care physician at UCSD, and he holds a sleep clinic at the VA in San Diego. He's also a postdoctoral research fellow focusing primarily on upper airway physiology and control of breathing, with support from the NIH, the Sleep Research Society, and the American Thoracic Society. So Dr. Nokes recently completed a mechanistic study of eXciteOSA, which he'll present in just a moment. But before we get there, I'll also welcome Dr. Lennon, who is dual boarded in sleep medicine and neurology, an assistant professor at the University of Tennessee Health Science Center, and also the facility director of the Neurology Clinic Sleep Center in Memphis. Dr. Lennon has quite a bit of experience now prescribing eXciteOSA, and he's going to share some case studies and talk about his experience integrating eXciteOSA into his practice. So before I hand it over to Brandon, brief housekeeping. We will certainly allow time for questions. So please feel free to put those in the chat and we'll do our best to collate them and get through them all. If we don't have time to cover everything, we will certainly get back to you afterwards. So I will stop sharing, and Brandon, hand it over to you.
Okay, so nice to meet everyone. I'm Brandon Nokes, again, pulm crit doctor over here at UCSD, and then I have a sleep clinic at the VA as well. I have no disclosures today. Again, I am funded by the NIH under a T32 with Atul Malhotra, who's my primary mentor, and then I'm an ATS Aspire Fellow, and I have a Career Development Award from the Sleep Research Society, where I investigate mechanisms underlying what's called negative effort dependence. So today I'll be talking about our experience with this eXciteOSA device. And for those of you who haven't seen it, so you can see on the left-hand side is the sort of intraoral apparatus where there are prongs that provide stimulation. And on the right-hand side, there's the charging attachment as well as the app. And then there's a remote control option that's available as well.
Brandon, I'm very sorry to interrupt. I'm not actually seeing your screen.
Oh, 1 second. Okay.
Perfect.
So I'll just backtrack a little bit. So there's the device on the left-hand side, the intraoral part of the device where you have prongs that provide stimulation. There's the charging attachment on the right-hand side, as well as the app that the patients interface with and that you can monitor remotely. And there's also a remote option that's available as well. The importance of this is, so there are a couple things to discuss. So one, OSA is really prevalent. And in fact, a recent paper from Atul Malhotra showed that it impacts over 1 billion people in the world if you include those with an AHI greater than 5, and that number is expected to increase with increasing age and increasing obesity. And it's thought that perhaps this almost 1 billion here was maybe even an underestimate. So that prevalence is expected to increase. And CPAP use is good, but it's not great. The reports of use are highly variable in the literature. And as you may be aware, there's currently a CPAP shortage, which at least here locally is creating at least a 2-month delay for starting CPAP within our VA. And for people with mild disease without excessive sleepiness, we're even deferring starting therapy with these limitations in mind. But that being said, so again, CPAP adherence is highly variable. Other therapies such as hypoglossal nerve stimulation are expensive and oftentimes time consuming. I can tell you here within the VA where I have a hypoglossal nerve stimulation clinic, the turnaround time is oftentimes 4 or 5 months before we can actually get people implanted and their settings adjusted appropriately. Dental devices too are also time consuming and not well standardized. Upper airway training loses efficacy as the training stops, so it's required that you keep up with it in order to maintain the benefit. The didgeridoo is kind of the classic example that everyone talks about, but obviously not everyone's going to play a didgeridoo. And then, so there have been prior tongue stimulation devices that people have used during the night, which have been problematic in that they end up leading to sleep fragmentation, or can be irritating and disruptive of sleep. And then surgical approaches for sleep apnea are not well standardized. The outcome metrics are not great, the share criteria, for instance. And then, yeah, it tends to work well for pediatric OSA, but not well necessarily for adult OSA as a whole. And the ideal patients for surgical approaches haven't been well defined. Again, here's just a picture of the device we'll be talking about, which is a daytime stimulation device that you use for 20 minutes a day. So prior work that's been done with this device, so it used to be called Snoozeel, now called eXciteOSA. This is from a group of ENTs over in the UK that we ended up working with, where they looked at the effect of using eXciteOSA on people with snoring. And this is the same group, and then adding in some ENTs from Spain, looking at individuals with snoring as a primary outcome, including those with mild OSA, but they didn't look explicitly at sleep apnea matrices in this particular study, showing that there was an improvement in snoring in this cohort. But you may be wondering, so why consider treating mild OSA? As you all are aware, the mainstay of diagnosing OSA these days is through home sleep test, which often underestimates the AHI. The AHI also varies night to night. So some individuals can appear to have mild OSA on their initial home test, and then if you do in-lab testing or repeat testing, that can vary considerably on a night-to-night basis. There is some prior data from Susan Redline and others showing an increased risk of hypertension, stroke, and atherosclerosis and mild sleep apnea, although admittedly there are conflicting data on this point. And then importantly, mild OSA is often accompanied by snoring, which can lead to social and marital discord, which is problematic, and it may worsen over time just through the natural history of sleep apnea in the upper airway. And so Atul and Bob Owens and I wrote an editorial about this in Journal of Clinical Sleep Medicine, talking about why do we sometimes ignore the chief complaint that people come in with, which is snoring and how it's impacting their life, and even the effects of mild sleep apnea. And it makes essentially all the points I made on my prior slide. that group that I mentioned, so the ENTs from Spain as well as the ENTs from the UK, we all teamed up to look at the effect of eXciteOSA on mild sleep apnea. And this paper is under review, which hopefully will be out soon. But on that study, so that we were looking at adults with an AHI less than 15 referred to ENT sleep from primary care due to being deemed as too mild for CPAP. Exclusion criteria were individuals who are pregnant, had implanted pacemakers, or other electrodes, and the AHI was, or if the AHI was greater than 15 on the repeat sleep study. Down at the bottom right, you can see the clinicaltrials.gov number if you want to dig into this in more detail. But 287 were screened for eligibility. 186 ultimately underwent a baseline overnight study, and 70 eventually started the device. 5 of those individuals ended up withdrawing over time, 1 because they became pregnant, 1 due to poor compliance, and 3 for personal reasons. But 65 had a follow-up overnight study after 6 weeks of daily use, and then 65 were ultimately included in the final analysis. And here's what we found. So the median age was 49, BMI was 27, baseline AHI was 11, and their baseline ESS was around 8, so not an excessively sleepy group. Mild, pretty minimal alcohol intake, no real smoking. And then you can see the neck circumference was around 15.5 inches. And then their adherence was actually quite good at 85%, defined as using the device as prescribed for 20 minutes daily. And so here's what we saw after the intervention. So the AHI went from 11.2 to 6.8, which was significant. The ODI also decreased, which is sort of a collinear metric. Objective snoring looked at through the sort of decibels of snoring also decreased fairly profoundly. And even though they weren't excessively sleepy, their Epworth improved, as did their PSQI. And this is just a sort of another way of showing that data. And you can see not the case for everyone. Obviously, there's some variability, but just to show that this is real world sort of physiology-based data. And then similar sort of trends for the ESS here. And again, this is just a different sort of graphical way of looking at these changes over time with AHI, ODI, and Epworth score. The side effects were pretty minimal. Many of these individuals actually overlapped. So most common was oral pulling of saliva, and followed by tongue discomfort, tongue tingling. If they had dental fillings, that being a bit sensitive, sort of nondescript tongue discomfort, and then one person who had gagging issues. And so we know that this device seems to work for snoring and mild OSA, but the question is how, and that's sort of where we really entered the picture at, sort of team UCSD, where we do a lot of mechanistic upper airway, control of breathing, and sleep research. And just to give some ideas about how we were parsing this out. So the upper airway is a complicated structure. There are 22 pairs of upper airway muscles, and they have different functions. But the genioglossus is the best studied due to its size as well as its accessibility. You can pretty easily access it anteriorly for EMG probing. And what we know is that despite there being a myriad of muscles, the genioglossus alone is both necessary and sufficient for maintaining airway patency in the context of evolving airway obstruction. And that's based on sort of an old Atomo Holter work, Mike Stantina, Amy Jordan. They've all done sort of great work to show this, that genioglossus in and of itself is necessary and sufficient. The images you see are from old Rich Schwab papers where you have upper airway MRI delineating the the anatomy of the upper airway, where you have a retropalatal region and a retroglossal region. And most of the collapse, at least based on this data, tended to be retropalatal in individuals with OSA. But retroglossal airway caliber also does decrease. The activity of genia glossus influences the diameter of both the retropalatal airway and the retroglossal airway. And then important to note, there are wake-sleep transitions that impact the activity of genia glossus. So as you go from even wake to N1 sleep, there's oftentimes a decrease in activity. And for many individuals, that gets worse as you get into REM sleep, et cetera, as you have relative muscle atonia. So our local study, we were looking to parse out, again, the underlying mechanisms of this device and how it is that it improved the AHI in people with mild sleep apnea. We admittedly had a difficult time recruiting over time. And you can see the clinicaltrials.gov number here, but we initially screened 77, 44 had a baseline HST, 31 had a baseline confirmatory PSG. And within this PSG, we also did genia glossal EMG to look at the output of genia glossus over time in the context of a sleep study. 22 ultimately started eXciteOSA, and those 22 also had follow-up studies, but 2 of them were non-adherent and ultimately excluded from the analysis, having to be called multiple times, reminded to use it, and still not using it, even though they were paid for their time. Here's a layout of how that looked. And just to mention, so this study design was similar to the UK-based study design, where we looked at training over the course of 6 weeks and then repeating our study. But the difference being that we had PSG and then genia glossal EMG. And when we looked at genia glossal EMG output, so there are 2 flavors to this. Broadly speaking, there are 6 different types, of genia glossal motor neurons, but the most relevant output is what's called the genia glossal inspiratory phasic activity, which you can think of as how much the genia glossus activates in response to inspiration. And then there's also this tonic activity, which is sort of the baseline postural activity of the genia glossus. And you can see that those changes were sort of all over the place. And didn't necessarily change over the course of 6 weeks of treatment with eXciteOSA. We used some non-invasive flow limitation matrices based on MATLAB analysis of the flow signal, and didn't see a big change in that as well. But it's important to note, so all those algorithms are from Scotty Sands, and part of our prerequisite of that is having pretty significant flow limitation at baseline, and usually people with an AHI greater than 15 in order to detect a meaningful change. So not seeing a big change in the flow limitation measured non-invasively is not all that unexpected, and from our standpoint was mostly sort of an exploratory thing to see if we could do it, to be honest. And then here is a tracing from Spike, which is the physiologic sort of sleep software that we use. And then on the top tracing, you can see these phasic outputs in genia glossus activity. And this is in a normal individual. And you can see that increased, phasic output oftentimes corresponds to increased, P-mask pressures. But again, these are just sort of representative tracings. What we did notice, however, is we looked at some other metrics using what's called the IOPE device, where you can look at both tongue strength and tongue endurance. We didn't notice a significant difference in strength, but we did notice that there's an increase in tongue endurance over time using this IOPE device. And the way that was defined is, so you've got this bulb that you press with your tongue, and you do a series of maximum maneuvers to get a gauge of what your maximum strength is. And the duration over which you can hold that maximum maneuver is how the endurance is defined for that particular test. And over the course of 6 weeks, for most of these individuals, there was a significant improvement in tongue endurance. to correlate with a change in their AHI. The AHI changes were also a bit all over the place. Some individuals had variable AHIs on their follow-up, and there was some report that some of the people may have had a drink or two before they came into the sleep study, which I think may explain some of that. But for those who didn't do that, there was a subset of what we call responders, where there was a big drop in their AHI from 19.7 to 8.4, which is significant within that study, but obviously, limited by the sort of small sample size of our study. Where I think things are headed next for this, and teasing out who the best candidates are for eXciteOSA, it's worth mentioning the idea of phenotypes and endotypes in obstructive sleep apnea, where a phenotype is how sleep apnea impacts someone. So are they excessively sleepy, for instance? Do they have do they just wake easily from sleep? Whereas an endotype, on the other hand, is how mechanistically their sleep apnea evolves. And whether that's due to their intrinsic anatomy, their inherent upper airway collapsibility, insufficient muscle activation, insufficient muscle endurance to maintain patency over the course of the night. All of those things end up being important. And the idea behind this is that underlying OSA endotypes may predict the underlying phenotypes. And then our lab obviously is very sort of dedicated to parsing out some of those nuances. But some examples of how this can be utilized and how endotypes matter. So for instance, in individuals with high loop gain, meaning that their chemoreflex sensitivity is heightened. So if you have a ventilatory disturbance and you over-respond to it by hyperventilating, that would be a high loop gain state where you're ventilating out of proportion to the ventilatory disturbance. Chris Schmigel is a brilliant guy in our lab, and he's shown that you can use oxygen and acetazolamide in individuals with high loop gain. Eric Kazarian up at USC is an ENT who's shown that UPP may be useful for individuals with what's called velopharyngeal compromise. The risk factors for OSA may be related to the underlying endotype. For instance, individuals with PTSD may have a low arousal threshold, and that's work Jeremy Orr did with Katie Sarmiento here at the VA in San Diego. The arousal threshold being how easily you rouse from sleep in response to a ventilatory disturbance. He's also got some work showing upper airway dilator dysfunction and neuromuscular disease, and runs a neuromuscular clinic here with those sort of ideas in mind. Brad Edwards has looked at sort of unique mechanisms of OSA in the elderly, and then other sort of work that's been done about how endotypes may predict treatment response. So for instance, individuals with high loop gain tend to develop central apneas, right? Just because they blow their CO2 down beneath the apneic threshold very easily. And they also have what's called a lower CO2 reserve. Individuals with a low arousal threshold may develop insomnia on positive airway pressure. And then actually, Brad Edwards and his trainees had some papers showing that high loop gain may predict surgical failure in individuals getting surgically treated for OSA. Just to highlight some mechanisms underlying sleep apnea, the ones we care about here would be the anatomy and then the pharyngeal dilator muscle activity during sleep. But other things that matter too are the arousal threshold, again, how easily you wake from sleep, the loop gain, your chemoreflex sensitivity, your lung volume, and in particular the end expiratory lung volume is inversely related to the P crit, or the collapsibility of the upper airway, and that's due to caudal traction on the trachea in response to increased end expiratory lung volume. And then there are vascular factors too. Individuals with heart failure and increased vascular congestion may have a worsening AHI as a result. One idea I'm interested in parsing out is I'm really interested in the idea of what's called negative effort dependence, where classically, when individuals have flow limitation, that flow limitation tends to sort of flat top and behave like a Starling resistor, where the flow limitation is fixed over a range of driving pressures. But some individuals, the more and more of an effort they take, the more and more airway collapse they get, and that's called negative effort dependence. And this has sort of two broad flavors, where this is what's called a cross-breath negative effort dependence. And you can see that across, so looking at PAPI, which is the sort of effort tracing here, as effort goes up, down in the bottom tracing, flow goes down, and that's a cross-breath negative effort dependence. And then there's also within breath negative effort dependence, where we say that the mid to sort of latter third of the inspiratory peak is where maximum effort occurs. You can see this scooping within the breath to correspond to the flow limitation in the context of maximum effort within a breath. And you can see that scooping in the flow tracing here, sort of fourth line down, these very scoopy breaths. So I'm interested in that, and actually I'll skip over this slide, but where I think it may be relevant is in what's called the tippy tongue model of flow limitation. And you can think of it in two ways. One being like if you're drawing blood from an IV, for instance, and you notice that if you draw too fast, the flow will stop, and that's because of the axial collapse of the vein. And in some individuals, the upper airway, we believe, behaves like that. And in so doing also may result in some displacement of the tongue posteriorly, resulting in this negative effort dependence and sort of scoopy shape of the breath. I've got some ongoing work to suggest that NED may be a mechanism that arises in the context of upper airway reflex failure, where normally in the context of flow limitation, your upper airway reflexes kick in, you're dilated or robust, your airway patency is restored, and so too is your ventilation, but not in the context of negative effort dependence. So I would like to investigate, and I'm sort of putting this out there too, whether or not people with negative effort dependence may be amenable, in particular to the therapy with eXciteOSA, given the impact on tongue endurance or genioglossus endurance that we've demonstrated. But there's a lot of work to be done. One is obviously defining the best endotype, right? The best mechanism of obstructive sleep apnea for eXciteOSA. I think multi-site trials will be relevant to better parse out, again, who the ideal candidates are, what are the limitations for when we can and can't use it. And then is it useful for more moderate to severe OSA? And then certainly over time, as we get more experience with this device, well, what are the long-term efficacy and therapy needs that evolve with these individuals? So I've said a lot of hardcore physiology, just by way of my own interest and practice. But I will hold off on any questions until the end, and thank you for your time.
Brandon, thank you so much for that really excellent presentation, and of course, all of the overnight work on data collection that had to go into it. So much appreciated. All right, so yes, please keep the questions coming in on the chat, and we'll get to those at the end. But for now, I will hand over to Dr. Lennon. Joshua.
All right. So I'm Josh Lennon. I'm a sleep neurologist here in the Memphis, Tennessee area. On staff at UT, but my practice is just outside the city of Memphis, called Neurology Clinic. We are pretty standard private practice with 8 physicians, a few nurse practitioners. We have a sleep clinic within the neurology clinic as a whole. We see generally somewhere in the ballpark of about 30 patients a day in our sleep side of the clinic, and our lab handles approximately 100 studies a month, give or take. Historically, it's about 3/4 in lab. We just got the results from last month, and it was right at 50-50 home study versus in lab, just to give you an idea of what our practice is like. Our diagnostic pathway shouldn't be all that surprising. We are a closed lab. We don't take any patients directly to the sleep study. They all come in for an evaluation first, and this helps us determine, an appropriate study. If we do suspect a low arousal threshold, whether say something like CBTI might be more appropriate first. In addition to a history and physical, every patient who comes into the clinic and not telemedicine gets an airway assessment, and we'll go over what that looks like in a few minutes. And then which test the patient undergoes really is determined by insurance factors, patient preference, and the indication. And our treatment recommendations have actually shifted quite dramatically over the last few months, as I'm sure it has for many of you. for so long, everyone was getting recommended to have PAP therapy first and foremost. And if and only if the patient had an objection or they tried and failed or they were intolerant, that then we would move on to some alternative, whether an oral appliance or evaluation with one of our local surgeons. That has been flipped over the last several months, where now we are primarily recommending PAP therapy only for patients with quite severe sleep apnea. And especially for those with mild and moderate OSA, we are recommending as first line a PAP alternative because we've had to ration our number of devices. In our region here, we have only approximately about 25% of the number of CPAP and BPAP devices that we had 4, 5, 6 months ago. And so we've had to be a lot more responsible with this very limited resource. And that really does require diverting more and more patients with less severe disease onto a PAP alternative. So we take into account patient preferences, the severity level, and then some anatomical considerations based on an airway test that we do. So as Dr. Nokes had just spoke to so eloquently, one of the main mechanisms of disease, and certainly not the only one, but one of the main mechanisms really is this neuromuscular relaxation that accompanies the sleep state. So whether somebody has a really tiny airway to begin with or not, they don't have constant apnea, they have sleep apnea. It really is this physiological shift that we see in the sleep state versus wakefulness that leads to this change in neuromuscular tone. And what this transoral device does is really help to target this contribution to sleep apnea pathophysiology by training and trying to improve the endurance of this genioglossus muscle. And there are some data, not with the eXcite device, but going back over about 15 years or so, demonstrating that perhaps one of the mechanisms here, as Dr. Nokes demonstrated with improved endurance, is a shift in the proportion of muscle fibers with a greater degree of slow twitch fibers and fewer of the fast twitch fibers. And that may be one of the mechanisms of how this exercising, this training from the stimulator actually affects tongue endurance. So who are appropriate candidates for the eXciteOSA device? Well, it's indicated for primary snoring as well as mild OSA. And this is OSA defined by the AHI, not the RDI for any of you out there like me who really define it that way. And to give you an even more fine-grained idea of screening patients here, in most of the studies, the sleep test that was utilized was the WatchPat, and I believe it was the WatchPat 200 when these studies were done, especially over in Europe. So you have to take that into consideration as we know that, especially in this range, that not all devices are created equal in the evaluation of mild OSA. But that really is the FDA indication is for mild, as well as primary snoring. Exclusion criteria, pregnant or if they may become pregnant, I have to tell you that we don't exclude, in my practice, women of childbearing age, but we do let them know that this device has not been tested on women who are pregnant. As Dr. Nokes spoke to in his trial as well, if they have electrodes or a pacemaker, that those patients are not going to be good candidates. And then if they have any metal in the mouth, whether from dental devices or if they've got a tongue ring or something like that, that might also interfere with the prosthesis. And then if they have a history of intraoral ulcers, that they should probably also stay away from this oral device. Now, the anatomical considerations that we utilize is with, we use in my lab, acoustic pharyngometry. So for the about 15-20% of patients that we see that come into the lab and are not doing telemedicine over the last year and a half, that we are continuing to screen them with pharyngometry. And this uses a kind of a clicking sound. It's basically like a sonar to take a picture of the anatomy of the upper airway to give us a little bit of a deeper picture that we get just with visual inspection alone. Now, the way that this is projected here, when the patient is breathing normally, that's the initial baseline. And then the patient is asked to basically exhale fully. And that's what the collapse graph comes from. Unfortunately, the way that these things are printed out, that only the collapse is blown up a little bit more. But this would be a patient after getting a better idea of their anatomy that we would just try to steer away from something like the eXciteOSA, because this individual really has an anatomical contributor to their obstructive sleep apnea. We said that there really is no difference between whether they are breathing normally or whether they are at end expiration, that the back of the airway, primarily, as we get a few centimeters deep here, this is right at the palatal glossal junction and then at the retropalatal retroglossal area. that whether they're breathing normally or at the end of expiration, there is extremely little space in this airway. So whether you strengthen or improve the endurance or do anything to change the activity of the genioglossus, it's not going to affect how terribly limited this anatomy is to begin with. So this is not a patient that we would utilize the eXciteOSA for. This would be a good patient, a good candidate for the eXcite. So on the initial airway, we see that right behind the teeth, there's a whole bit, a large amount of space. Right under the palate, it collapses down just ever so slightly, but still right around 2 to 2.5 square centimeters of space. And then the retropalatal, retroglossal area, it opens very, very wide. So there's a whole lot of space. They have very favorable anatomy. This is not someone that you would expect just looking in their airway that they would have sleep disorder breathing. But then at the end of expiration, we see that the palate has collapsed down, the tongue has fallen backwards, and there's a lot less space here than there was just at baseline. There's still plenty of room overall, still well over 2 square centimeters of the space in the retropalatal, retroglossal area, so plenty of space. So this is likely someone who doesn't have obstructive sleep apnea, but probably more primary snoring, that you can almost visualize this as like this is the flap of the palate. And as they expire, the palate is really collapsing down. It provides a lot of wiggle room for that palate to vibrate and cause the noise of snoring. So this individual has much more favorable anatomy based on acoustic pharyngometry for neuromuscular stimulation. This would be an even better candidate. So again, we have at baseline a very wide open airway, especially retropalatal, retroglossal, just a whole lot of space in their airway, just a cavern when you look down their throat. But then as soon as they expire, this muscle tissue is so floppy. It is so dependent on the slight degree of intrinsic PAP of the pressure exerted by the flow of their own breath is stabilizing and holding on this tissue open, that as soon as they expire, all that tissue just comes collapsing down, and we see a near closure of their airway just from breathing out. And so this is someone with very, very favorable anatomy with very poor muscular tone. And so this would be a great target to try to improve the tone and improve the endurance of the genioglossus muscle to really dilate their airway, whether they're awake or asleep. So to go through a couple of cases here, this is the first one is a 77-year-old lady. She came to us with a complaint of snoring for her husband. She was tired and fatigued during the daytime, but not necessarily sleepy. She was waking up a few times a night to use the restroom. She had dry mouth in the morning, and then she'd recently suffered a non-disabling stroke. So she underwent a PAT study. Her PAT AHI was 9.2, so in the mild range. This was a little over a year ago. So initially, she was started on PAP therapy because those devices existed and they were available back then. Her range was narrowed down to 7 to 10. We thought she was doing absolutely fantastic. You can see her hours of usage were just shy of 8 hours every single night. She did not miss a single night of therapy. We were quite pleased looking at all this data, but she was quite miserable. And so she was really looking for an out for some other alternative. And so shortly after the eXciteOSA device became available, we thought that she would be a great candidate for this. So in the trials, most of the data that we're seeing is after the first 6 weeks of use. And in those first 6 weeks, they call this phase 1, and this is where the patient is utilizing the stimulator for 20 minutes every single day. That's what they're instructed to do. And after the first 6 weeks, then in phase 2, they're asked to use it at least 2 times a week. And so this patient, is now in her 20th week of use of the device. On average, she's using it about 4 days a week. So, more than the baseline minimum recommendation after those initial first 6 weeks. There are 15 levels of intensity of how strongly it's stimulating the tongue. And you can feel this, whether it's a set out of 1, you can barely feel anything at all. You can start to feel it, 4, 5, 6, 7. 10 is rare. It's starting to get a little bit more intense, and it maxes out at 15. So she was, getting up there in an intensity level and really sticking with it. She actually just underwent her follow-up study over the weekend, and so we're waiting for that study to get uploaded back up to find out how she's done after about 20 weeks or so with this device at home. At least for her report, subjectively, she's doing a lot better. She's much happier with this than she was with CPAP, even though I was thrilled with her CPAP use, but she's much more pleased with this device that she uses during the daytime and not having to deal with anything overnight. Our next patient, rather than mild OSA, this is a patient with primary snoring, a 36-year-old male whose bed partner was complaining of occasional snoring. There were no daytime symptoms whatsoever, just really prompted by the bed partner's concerns. underwent a home sleep study with an REI of just under 4 events per hour, spent about 2% of the night snoring. Oxygen parameters look really good. Amino2 right around 95%, didn't drop below 92. So overall, looked pretty good, but did have some snoring that was confirmed. And given the chief complaint, we did want to treat this as well. So started this individual on the eXciteOSA device. Individual is now in phase 2 after completing those daily sessions for the first 6 weeks, and now is in week 27 overall. Has used the device, again, 3 to 4 days a week or so, 55% of the days overall since the very beginning, and has consistently ramped up the intensity level and is now using at a level of 15 out of 15, so the max level of intensity for maximum stimulation each time. This individual did have a follow-up sleep study during the 16th week of use. And over the course of those 16 weeks of use, we saw that the respiratory event index has dropped from about 3.7 out of 0.1, so significant improvement in the number of events that occurred overall. And we went from not a whole lot of snoring to begin with, but dropped from 1.9% down to 0% of the study spent with snoring. So snoring basically completely resolved with about 4 months of use of this device. The mean oxygen had creeped up a little bit from about 95% up to 97, although the nadir did drop slightly from 92 down to 90. The bed partner report is very positive. The patient himself hasn't really reported any change, again, because there wasn't really much of a complaint on his part to begin with, but his wife is quite pleased with it. So, again, the perspective here is that, we are in a CPAP crisis. I would argue we were in a CPAP crisis well before this, and really about our trouble with adherence. But now we've got this whole new issue of device availability. And that has forced us really to ration, to find out, what devices are available and who should get them first and who should be allowed to wait. And that means that, for some individuals, especially those with a more complex apnea, a mix of central and obstructive, that PAP may be their only option or only single option to get under control. But for a great number of patients, primarily those with mild and moderate disease, we really need to be more diligent about exercising other options beyond PAP therapy. And so this has traditionally included things like oral appliances, whether tongue retaining devices or mandibular advancement. There's a couple of great positional devices out there that are FDA cleared. Weight loss, whether medical, surgical, or dietary, is a great option. Surgery, again, for kids seems to work great, although there's some controversy about watch and wait versus a TNA. UPPP has kind of been a little bit all over the place. There's some controversy there, but I think certainly since hypoglossal nerve has come into play over the last several years, I think that has really opened up the viability of surgical options. But now we have something that is, almost similar to the hypoglossal nerve stimulation of really affecting the genioglossus, but this is more direct stimulation rather than of the nerve itself stimulating the muscle. And this is done transorally. So rather than having to go through an invasive procedure, wait a month for everything to heal, finally turn the device on, and then have it stimulating while you're asleep, which we, again, just like CPAP, would be worried about those with a low arousal threshold. This is something that's done during the daytime and is at least an order of magnitude less expensive than the hypoglossal nerve stimulator. So, this is just our single center experience. We have had to change our clinical practice because of events out of our control and that really had nothing to do with the availability of this device. But I think because it's out there, it has been a great option for many of our patients. So for every single one of our mild to moderate patients, we are first line, offering a non-PAP therapy, which was sort of a 180 from what we were doing, just 6 months ago. And also, we have about 30 patients so far on treatment with eXciteOSA. And, I've never seen this with any of my CPAP reviews, is that of all our patients, this is, again, I just pulled this from the portal yesterday, we only only a single patient who's not adherent to therapy. It's much easier to just do 20 minutes a day rather than having to put up for at least 4 hours a night, most nights with CPAP. So the bar for adherence is far lower. And so it makes it easier for patients to achieve their stated goals. And so there's certainly a great degree of preference there from our patients. And we've gotten a lot of great feedback from those that have used it as well. And with that, I'll hand it back over to Dr. Backer, and I guess we'll head to Q&A.
Wonderful. Thank you, Joshua, very much. Really nice to see those real world examples and your experiences alongside all the physiological information that Brandon presented. So Okay, we do have some questions coming through on the chat, so please feel free to keep entering those, and I'll do my best to pull them all together. One, though, is can we go into a bit more detail on patient selection? So how do you go about finding a patient likely to respond? And do you recommend acoustic pharyngometry for all patients? So Joshua, you touched a little bit on that in your talk. So perhaps, Brandon, if I can ask you to answer that first.
Sure. I mean, again, I don't think the ideal sort of patient population is defined, but at least based on the data we have, those with snoring or mild sleep apnea who are not amenable or are not receptive to CPAP, and certainly in the context of the current national CPAP shortage, where again, at least here at VA San Diego, it's taking over 2 months to get CPAP. Certainly we would consider those individuals for eXciteOSA. And then with respect to acoustic pharyngometry, not everyone does that. So I don't know how tenable it is to routinely instrument as a way of screening for who's the best candidate, because that does take some practice and expertise.
Absolutely. Joshua, anything you'd like to expand on that topic?
Yeah, I think, pharyngometry is a really nifty toy to have in our arsenal. And, frankly, it's not reimbursed most of the time. We used it primarily, at least at the beginning, as a way of helping to show for patients themselves who are staring in the mirror and opening up their mouth, what really could be happening in their airway, not just what the anatomy is like and how open or closed off it may be, but how collapsible it may or may not be. And so we used it more as a way of trying to convince the reluctant masses that this is something that they should take seriously. And with that data that we have there anyway, that does help us to steer a patient towards more of a purely mechanical solution, say like surgery or an oral appliance, versus one that really is targeting primarily this neuromuscular issue like the eXciteOSA. But it's an expensive device to get a hold of in the first place. And I certainly wouldn't recommend it for everybody, but it is something that we have found somewhat useful.
Yeah, and one thing I'll just very quickly add to that question is that in the clinical trial that Brandon presented early on, as history to his talk, acoustic pharyngometry was not used as a screening tool in any of those publications done so far. So, that the exclusion criteria followed the device contraindications, as well as some things like symptomatic nasal pathology, some skeletal abnormalities, things like that. Okay. Yeah, go ahead, Brandon.
Oh yeah, they use the Friedman score within that as well to assess their individual anatomy. So. Right.
Okay. Side effects. Joshua, I might ask you to expand on this a little bit. So what kind of side effects are you seeing? How long do they last? And are they permanent?
Yeah, we haven't seen anything outside of what was reported in the study. So, the issue of salivation certainly comes up as the most common side effect reported. In our patients, we hear it from probably about half that they're experiencing salivation. We have only heard from a couple people that they've had some tooth discomfort, primarily in and around their fillings. I think the key here is that, say, versus pharmaceutical interventions, is that these side effects are really only limited to the duration of use itself. So during those 20 minutes, they might have salivation, and then they take the device out when they're done with their therapy, and then there's no more excess salivation. Or if they have some tooth discomfort, they might shift the stimulator slightly within their mouth, and that discomfort goes away. So we haven't seen anything exotic, and any side effects that are reported are exclusive to that 20-minute session, if not even shorter than that, and go away as soon as the session is over. And more importantly, and we certainly see this with mandibular advancement devices as well, is that especially in regards to salivation, it's present early on, and then it basically disappears over the next several days to a couple of weeks. And so even those who are reporting these kind of effects early on in the course of treatment, within a matter of days to weeks, that almost all of them, these adverse effects have really resolved.
Great, thank you. Brandon, you talked about the genioglossus endurance and strength, and I wonder if you can just elaborate on those two characteristics and how they relate to collapsibility.
Sure. So I mean, this is something that's pretty well studied, dating back to, David White, Amy Jordan, Atoma Holtrep, all the way back to the 90s. But the strength of the genioglossus in individuals with OSA is oftentimes more robust at baseline. So having increased strength of the tongue isn't necessarily the best predictor of the collapsibility of your upper airway. Alternatively, the endurance side of things from our data is relatively novel in showing that increased endurance portends to a decreased AHI, at least in this context, which is pretty cool to see.
Yep, absolutely. Thank you for clarifying. Okay, question here from the chat. It's long, so bear with me, but it's interesting. For patients with mild OSA and severe daytime tiredness, how do we monitor the response? When should we be doing repeat sleep studies to see if there's an improvement? And what about the Epworth score? Joshua, would you like to try to tackle that series of questions?
Yeah, sure. I mean, this is something that we've been trying to figure out ourselves as we go along. In the clinical trials, most of these follow-up studies were done after 6 weeks. So they used the device daily for 6 weeks and then had their second study right then. We ultimately decided to go for a approximately 3-month interval between when they started and when we retest them. And this is because the responder rate, we're hoping would be pushed up a little bit more the longer somebody does it. There was not a whole lot of justifiable reason for why we just landed on 3 months, but that's just what we elected to do, and we didn't really know that going in. This is something we're trying to figure out as we went. In terms of patient response with tiredness, we haven't had anybody with really severe daytime sleepiness. So I think the highest Epworth that we've had for one of our patients on eXciteOSA has been 14. But we haven't really dealt with any profound sleepiness. And I think one of the things that we are counseling our patients on when we're discussing this treatment as an option in the first place is that, say, unlike a titration study, whether it's an oral appliance titration or PAP therapy, where the patient could wake up the next morning and say, like, I haven't slept like that in 25 years. You don't get that with a single 20-minute session with this device. It really does take time. This is like, your tongue is training for the marathon of sleep, and that it can't happen in such a short amount of time. And so I think that also weeds out some patients who are really expecting or want something much more immediate, that there is a little bit of a delayed gratification there. And so most of our patients are expecting that whatever daytime sleepiness they have is not going to get better on the first try or the second try, that it may take several weeks. And the peer review data that we have it demonstrates that as well, that it really is a matter of weeks that we're seeing these effects.
Great, thank you so much. Brandon, I might send this one your way. We've actually had several questions on this topic, so I'm going to try and bring them all together. Basically, these questions are looking at the indications. Mechanistically, would the device be effective for those that fall outside of the OSA range that we've been looking at so far? So moderate OSA, severe. If you can, this might be more speculation, but if you can touch on that.
Sure. I mean, the short answer is we don't know yet, because that's not explicitly what's been studied. And then, yeah, so the short answer is we don't know. And that sort of speaks to the need for the trials expanding the indications if available. And, on the other hand, too, if we study moderate OSA and find that it's not effective, that's also useful to know. But for now, I don't think that's been fully parsed out.
I think
Joshua, anything? Yeah, go ahead.
I think the patient with the highest AHI that we've put on therapy was 16.1. And, I felt like I was breaking the rules when I did that. So, we've not ventured out and put anybody with, really moderate, high 20s, or certainly no one with severe OSA have we tried this with yet. But I think, something to keep in mind with, as we look at basically every non-PAP alternative treatment for sleep apnea is that there's generally a responder rate, and then there's generally a percentage reduction in severity. So whether you're looking at AHI, RDI, ODI, T90, and so I think what we would like to see with some upcoming data is, should we expect an absolute number decrease in AHI with something like the eXciteOSA, or should we be expecting a percentage reduction? And depending on how which one of those or which one is the stronger influence, that if you take somebody with more moderate OSA, you might get from moderately moderate to only mildly moderate, which is may not be a sufficient solution in and of itself. Whether that reduction is by 4 or 5 events per hour, or a reduction of 45% or so of the AHI, that I think most likely I would anticipate that for either one of those populations, I don't think we would see significant enough improvement that even if you have a cutoff for responder rate of 40-50%, you may say that a number of people respond. That's not quite the same thing as being clinically meaningful, where this could be an adequate standalone treatment based on the data that we've seen so far. Although I'd love to be proved wrong.
Well, you actually both touched on clinical trials in general, and it's certainly something that our team's been putting a lot of thought into as to where to go next in terms of trying to answer these types of questions. Okay, so one question that's just come through on the chat, it's touching on the adherence rates, both in the studies mentioned today, as well as, Josh, what you've seen in clinical care and what we've observed across our patient pool through remote monitoring. How do you keep patients motivated? What kind of support do you provide? What are you doing for patients in the off time between appointments?
Yeah, we're trying to, again, because we don't really know what we're doing, so kind of making it up as we go. So we're trying to follow the same model that we do for CPAP, which is, there's a lot of discussion up front. We're trying to prepare them so they know what to expect. We try to have a touch point, after day one, after the first week, after the second week, and then usually we'll see them in the clinic at some point between the first, 7 to 15 days or so, and then a second appointment about a month later. And then, actively encourage them to reach back out to us at any point in between. There is a portal. And so I think anyone who's used CPAP over the last 10 years is familiar with these things. And so, you can be alerted, when somebody is non-compliant, you sort of check on their progress on a daily basis. And so we've not done this yet, but there's certainly a possibility that you could be even more proactive at specifically targeting those who are falling behind in their days of use. We've not done that yet, but we have found that taking a similar approach that we do to CPAP patients, that we've never had fewer than the 9% of our patients on the therapy not be compliant, and typically it's between 0 and 2 that are non-compliant, out of a few dozen.
Well, that's actually a very nice way to wrap up our talk, or talks, I should say. Thank you, everyone, very much. It's getting to the top of the hour, and I do want to finish on time. Just to mention that we will see a log of all of these questions that are coming through the chat. So we'll reach out and make sure that we get some of these answered, because we didn't get anywhere near through the volume of questions that are coming through the door. So again, Dr. Nokes, Dr. Lennon, thank you both very much for your time, and for everyone joining.
Thank you so much.
Thank you.